Today we're going to talk about emphysema. The main goals of this talk are to understand the risk factors for emphysema, how to recognize the symptoms of emphysema, and how to evaluate a patient with these symptoms, as well as to understand how to assess disease severity and be familiar with the various therapies available for managing emphysema. These are the slides that we'll be covering in this lecture. Chronic obstructive pulmonary disease, or COPD, comprises a spectrum of disorders that are characterized by irreversible airflow limitation and dyspnea. These disorders are differentiated from asthma in that the airway constriction and inflammation is reversible in asthma. The most common subtypes of COPD include emphysema and chronic bronchitis. Flow of air through the bronchial tree is directly proportional to the driving pressure and inversely proportional to the resistance. In emphysema, decreased elastic recoil leads to decreased driving pressure and therefore decreased airflow through the bronchial tree. In chronic bronchitis, increased resistance from bronchoconstriction throughout the bronchial tree leads to decreased airflow. Many patients with COPD have components of both emphysema and chronic bronchitis. Emphysema is defined by destruction of the lung parenchyma, leading to enlargement of the air spaces. While fibrosis is common to the interstitial pneumonias, this is not the predominant pathology seen in emphysema. However, there can be some increase in collagen and fibrosis. The pathogenesis of emphysema is not completely understood. Inflammatory cells, neutrophils and macrophages in particular, are responsible for delivering elastases, matrix metalloproteinases, and other proteases to the lung tissue, and this suggests that inflammation is a key part in the development of emphysema. Inflammation also leads to edema, increased mucus production, and this further serves to narrow the airways. The beta-2 receptors are responsible for constriction and dilation of the conducting airways. There has been some demonstration of hypersensitivity and stimulation of these receptors in the development of emphysema. Of note, tobacco is a known irritant that activates the beta-adrenergic pathway. The key symptoms associated with emphysema include worsening shortness of breath and chronic cough. On examination, patients with emphysema tend to have hyperresonance to percussion and rhonchi, wheezes, and crackles on auscultation. Patients with end-stage disease may adopt positions that relieve dyspnea. For example, patients may lean forward, they may have an increased work of breathing with evidence of accessory muscle use to breathe, expiration through pursed lips, and paradoxical retraction of the lower interspaces during inspiration, and this is referred to as Hoover's sign. Advanced disease leads to loss of vasculature in the destroyed alveolar walls, which in turn causes increased pulmonary pressures secondary to decreased area for blood flow. Increased pulmonary pressure then leads to right ventricular failure and a phenomenon known as cor pulmonale. As the disease progresses, end-stage cachexia can occur. Assessment of patients with emphysema can happen in many ways. Pulmonary function tests are crucial to establish the diagnosis and to assess severity and response to therapy. Chest X-ray is most notable for flattened diaphragms and expanded lungs later in the course of disease, but may be normal earlier on. CT scan can allow for better viewing of the lung parenchyma and may identify bullous changes. As the disease progresses, secondary polycythemia occurs as a response to chronic hypoxemia. Evaluation of oxygen saturation and ABG is useful in establishing need for therapy and oxygen supplementation. The natural progression of the disease begins with mild hypoxemia followed by hypercapnia. Over time, there's resetting of the chemoreceptors, which allows for a higher level of CO2 in the blood. As mentioned earlier, PFTs are the mainstay of assessment for emphysema. Testing identifies the airflow obstruction with reduced maximum expiratory flow that characterizes emphysema and is known as the FEV1. This decrease in FEV1 is out of proportion to the decrease in FVC, and this ultimately leads to a significant drop in the ratio. Increased lung volumes from hyperinflation caused by the decrease in elastic recoil can be seen on pulmonary function tests as well, and this is seen by the increase in residual volume, functional residual capacity, and total lung capacity. Increased lung volume leads to flattened diaphragms, shortening of the muscle fibers, and further reduced contractile efficiency. Destruction of alveoli leads to decreased surface area for gas exchange, as evidenced by a decrease in the DLCO. The GOLD staging system is widely used to categorize patients by disease severity. With this system, results from pulmonary function tests help to assign severity stage. A reduced FEV1 to FVC ratio of less than 70% predicted is necessary to classify a patient as having COPD, while the FEV1 is the main determinant of severity of illness. A large part of caring for patients with emphysema is helping to avoid complications such as pneumonia. The influenza vaccination should be administered each year. This is the most effective intervention aimed at reducing morbidity and mortality from COPD. The pneumococcal vaccine should also be given to adults with emphysema. Smoking cessation is crucial to prevent further lung disease, and cessation of tobacco use can actually lead to some degree of disease regression. Medical interventions are aimed at relieving airway obstruction. There are two types of medications that result in bronchodilation. Sympathomimetics target the beta-adrenergic receptors, while anticholinergic agents target the acetylcholine system. Both of these agents come in both short and long-acting preparations. Anti-inflammatory agents can be administered in either inhaled or systemic preparations. Systemic therapy comes in both oral and IV forms. Though chronic use of inhaled steroids does not seem to prolong survival, it does help to improve symptoms and to decrease exacerbations. Systemic steroids are used in acute exacerbations. Mucolytics can help to loosen mucus so that it's more easily cleared from the airways. Other potential agents that can be used for emphysema are listed here. Pulmonary rehab helps to improve quality of life, and this largely focuses on nutrition, since malnutrition and cachexia can lead to decreased muscle strength and an altered immune system. Surgical options are available but are not largely used at this time. Oxygen supplementation is the only intervention that has been shown to improve survival. The mainstay of management for emphysema is pursued in a stepwise fashion, depending on disease severity as defined by the GOLD stage. Bronchodilators and glucocorticoids are the most studied and widely used medications. In summary, emphysema is one of the subtypes of chronic obstructive pulmonary disease. Emphysema is characterized by decreased elastic recoil and airspace enlargement that leads to irreversible obstruction of airflow. Pulmonary function testing is the best method of evaluating severity of illness and will identify degree of obstruction and increased lung volumes. The GOLD staging system is used to stratify patients based on severity of disease, and this is then used to determine appropriate therapy. Key management of emphysema includes smoking cessation, prevention of complications, and relief of airway obstruction by means of bronchodilators and anti-inflammatory agents. These are the resources used to prepare this presentation, and these can be used for additional information.